Welcome back to the Ninja Nerd Podcast. We're continuing our trilogy on anemia. We're now moving into normocytic anemia. Super quick topic, right?
It's going to be so quick. You'll never see it. Like, it's just going to, time's going to blow by so quickly.
It will, because it's going to be super fun.
I think it will be. Yeah, it's a lot. We got a lot of cases, up to 8 cases. So there's a lot, but I think it'll be fun. I think you'll learn a lot. I think it'll be a nice way of really, I think, summarizing all of the normocytic anemias.
Awesome. As always, if you all could, please make sure to comment, like, subscribe. Please sign up for a membership on our website. We have a lot to offer there. Just check it out, and you will not regret it.
Yeah, really, I'm serious. I think it would be an amazing tool to have for you. It'll help you fire on all cylinders when you're in class and trying to learn all this stuff.
Let's do it now. So 8 cases, like Zach said. We're going to go through each one. Try and guess each case as we go to see if you can kind of diagnose the condition.
Yep.
All right. So let's start off with case 1, Zach. We have a 25-year-old male. He presents with fatigue, frequent infections, and easy bruising all over the last month. His HPI, the patient reports progressive weakness and fatigue. He also has noticed an increase in nosebleeds and small bruises on his arms and legs without significant trauma. He denies recent illnesses, fever, or weight loss. For his exam, we get some vitals. BP is 120/75, heart rate 92, temp is 37.1 Celsius. His skin, it looks pale with multiple petechiae and bruises on the extremities. There is no lymphadenopathy or splenomegaly. We do some lab findings. We get some back. We have a hemoglobin of 8.5, white blood cell count 2,500, platelets of 40,000, a reticulocyte index less than 2%, and an MCV of 90. So some red flags right away there.
Yeah.
What's the most alarming thing for you with the lab findings?
Well, definitely, obviously, with this case, the anemia, and then some other aspects here are the other cell counts. Not just the red cell count is low, but the white cell count's low, the platelets are low, and then the bone marrow's telling me it's not working. There's a lot of things that kind of like scream some concerning features here.
With the platelets being this low, is that why you think there's lots of petechiae, bruising, things like that?
Yep. I think that's the common reason. The fatigue is probably from the anemia. The frequent infections are probably because of the drop-off in the white cells, and the easy bruising is probably from the drop-off in the platelets. So we would call this pancytopenia whenever all cell lines are dropped.
Okay. So at least right now, the clinical picture, the lab findings are matching up.
Yeah. Yep.
Okay. Based on the lab findings, what type of morphological anemia are we dealing with, and what does it suggest?
All right. So I would say when we look at these, any kind of anemia, same kind of like process. What's the hemoglobin? Is it less than the threshold? In this case, it is. This is a male, so hemoglobin less than 13 for a standard value anemia. Then look at the MCV to determine the morphological state, as you said. Is it less than 80? If it is, then it's in the micro. If it's 80 to 100, it's in the normocytic range, and this is, for that case, 90, so it's in that normocytic range. So we have a normocytic anemia. The next part of the algorithm, I would say, is to look at the reticulocyte index. And so the reticulocyte index basically is a parameter or harbinger of how well the bone marrow is working. So the lower the number, the less work the bone marrow is doing. Because the reticulocyte's like the immature red blood cell. It's like the red blood cell, kind of like in the lineage as it goes through its whole process of proliferation and differentiation, starting from a stem cell all the way to the red blood cell. The reticulocyte is just one point right before the mature red blood cell. So it's a way of kind of telling how our bone marrow is working. So if the reticulocyte index is less than 2, that tells me that the bone marrow is not really working very well, and it's not helping me to generate red blood cells. So I know that that's not a good sign, and that tells me it's called an underproduction anemia. If it was greater than 2% and it was pretty high, some textbooks will actually be a little bit more safe, I'd say, and they go up to 3%. But anything like that suggests a rapid turnover, and it tells me that their bone marrow is really having to work hard. It might be hemolysis or blood loss. So since it's less than 2, definitely concerned of an underproduction. So with that being said, I have an underproduction anemia, and when I have an underproduction anemia, that leads me to 2 big differentials. Aplastic anemia as one of the big things there for a bone marrow failure, and then second would be anemia of chronic disease. This patient's 25 years old, and they don't have any underlying history that suggests chronic diseases that would make me think that. And anemia of chronic disease is a tougher one. And anemia of chronic disease won't present with pancytopenia.
Okay.
So the way I go to my next part of my algorithm is, now that I've determined it's underproduction and it's anemia of chronic disease as a part of it, or aplastic anemia or some kind of bone marrow failure, the next part is there other cell lines affected? If other cell lines are affected, it's a bone marrow problem. And that's when I would say, okay, something's not right here. This could be aplastic anemia, or I could have cancer that's actually infiltrated into the bone marrow. So something called MDS, myelodysplastic syndrome, or even leukemias. Leukemias can infiltrate the bone marrow and make it hard for the actual blood cells to actually be formed. So those are my thought processes here. I would have to take it another step, though, to really kind of figure that out, to figure out what my actual answer is. But right now, I'm stuck at like aplastic anemia or some other type of malignancy being the cause.
And again, aplastic anemia, because with pancytopenia, that would be more present with aplastic versus
anemia
of
chronic
chronic
disease.
disease.
Exactly.
Okay.
Yep.
That makes sense. All right. Next question here. Now that we know this is a normocytic anemia, as you kind of delineated, what would be the next test to suggest hemolysis or blood loss versus underproduction of red blood cells?
So funny enough, I think the reticulocyte index would be a way of at least kind of getting an idea if it is hemolysis versus blood loss, or hemolysis, blood loss versus underproduction. So again, kind of going back to that, reticulocyte index less than 2, bone marrow is not performing. Reticulocyte index greater than 2, the bone marrow is performing, and it's probably having to compensate because we're probably chewing up or losing red blood cells, and the bone marrow has to pump them out a lot faster. But to even be better to determine if something is hemolyzing, I would actually order, and we'll talk about this probably in another case, LDH and haptoglobin and indirect bilirubin levels. And I may even get like a urinalysis to look for hemoglobin in the urine. And those are really good ways of determining if there's hemolysis. Blood loss, oftentimes in the vignette or in the patient, like when you look at them on the bedside, you'll be able to tell if like they're exsanguinating, if they have evidence of a GI bleed, if they're having postpartum hemorrhage, something like that.
Sure.
Those are a little bit more obvious. So hemolysis is a little bit tougher. It's not going to be super visible. And for those, you would have to order those labs like LDH, haptoglobin, and indirect bili to really kind of get a better idea. That's kind of the way I would go about that. But I think, again, we kind of covered that already.
Right. With a low reticulocyte index and pancytopenia, what would a bone marrow biopsy likely reveal if aplastic anemia, as you said, is suspected?
Yeah, so I think that, again, we talked about this. I have a suspicion very strong for aplastic anemia, given that pancytopenia, given the low retic. A bone marrow biopsy is the only way that you can truly definitively diagnose this disease. So what you'd have to do is you'd have to aspirate out the bone tissue aspirate out of the bone tissue some of the hematopoietic stem cells. And what you'd have to see is that you pretty much have destroyed all these hematopoietic stem cells. So it would be what's called hypocellular. So usually you should have a normal amount of cells that are kind of like different in the bone marrow. In this case, because you're destroying all the hematopoietic stem cells, or they're not working properly, they're not going to proliferate and differentiate and make enough red blood cells, white blood cells, platelets. So I'd expect very little cells. But here's the big thing. The cells have to be the same, like normal morphology. They're not too big and they're not too small. Because the reason why is, let's say that I ended up getting a bone marrow biopsy and it was hypercellular, then that suggests either MDS or leukemia. The only way that you can differentiate those two is based upon the number of blasts. So if it's less than 20% blast cells on their morphology, then that's MDS. If it's greater than 20% blasts, that suggests leukemia. And then you determine if it's AML or ALL based upon the type of stem cell they have. But that's the way you'd have to say it, is hypocellular bone marrow, which is probably having a lot of fat and normal morphology of the red cells. That would be the way that we would say this one.
Treatment's going to be huge for this one, especially with how young this patient is.
Mm-hmm.
If confirmed, can you explain the treatment options that are available for aplastic anemia, especially considering things like age, donor availability?
Yeah. So this kid's pretty young. And so we say anything less than 50, you should really work hard as you possibly can to get an allogenic bone marrow transplant.
Right.
So that's what I would want to do, is I'd want to find some type of like donor match, probably like a sibling of sorts.
Mm-hmm.
And as long as we can find a match and this patient is less than 50 years of age, we usually kind of use it as like a rough cutoff to say, hey, this is a patient that we should really consider as a bone marrow transplant. If they're greater than 50 or they can't find a match, then we try and do other things in the meantime until we can try and possibly get them a match or get them a transplant. And so you have to kind of suppress your immune system, because aplastic anemia is an autoimmune disease oftentimes. More times than not, we don't know the reason. There is a lot of things that can cause it. Drugs are a big one. Chemoradiation is another one, but it's often autoimmune related. So you have to kind of suppress the immune system from further damaging the bone marrow, like the stem cells there. And so we can give them things like cyclosporin and like anti-thymocyte globulin. Those are drugs that we can use to suppress the immune system from damaging the stem cells. But eventually we have to transplant.
All right. Well, there's case one.
Yep.
Let's move on to the next case, and same thing. Try and guess it. There might be some similar questions, but we'll kind of have a nice repetitious way of approaching these diseases.
We're gonna honestly, it's gonna get to the point where you're like, okay, I can diagnose any kind of anemia after this.
Yeah, like these lab findings, you're gonna know right away. All right, I know exactly.
Bro,
what
hold my
norm
beer.
is.
I got this one.
That's awesome. That's how it should be, though.
Yeah, hopefully that's the whole point. If you get an approach, anything should kind of be a little bit more straightforward. It's just you have to have an approach and you have to do it repetitiously oftentimes.
Right. Yep. All right, case 2. We have a 34-year-old male presents with dark-colored urine in the morning and episodes of abdominal pain. His HBI, the patient has noticed that his urine is particularly dark in the morning but lightens throughout the day. He also experiences occasional abdominal pain and fatigue but has no recent infections or any new medications. For his exam, his vitals, BP is 130/85, heart rate 95, abdomen, he does have some mild right upper quadrant tenderness. There is no petechiae and there is no jaundice present. For our lab findings, we get back the following. All right, so we have some lab findings. We get back the following. Hemoglobin of 9, retic index greater than 2%, LDH is elevated, haptoglobin decreased, indirect bilirubin elevated, and an MCV of 92. We're getting some of those tests we discussed in case 1, so there's a little bit more here.
Yeah, exactly. So now we got some of those hemolytic labs, which is cool.
All right, so based on the lab findings, what type of morphological anemia are we dealing with, and why do you say that?
All right, so again, we're going to kind of stick to that same framework where we're going to say male, hemoglobin less than 13, definitely anemia, so the hemoglobin's 9, so we're good. Then we're going to go to the next step in the algorithm, which is looking at the MCV. Is it less than 80? That would be microcytic. Is it 80 to 100? That'd be normocytic, or is it greater than 100? Falls in between that 80 to 100. So this would be a normocytic anemia. Normocytic anemia is an insanely wide differential. So then from there, the next step that we'll talk about is kind of how do I know if it's the bone marrow working or the bone marrow is working, but there's other processes that are going on that's causing loss or destruction of red blood cells.
Based on the findings of the retic index, what would be the next test you would consider given the presence of hemolysis blood loss?
All right. So from here, now that I've done that, that's the thing that we talked about. We checked out the MCV. We know it's 92. We're in the normocytic range. The whole point now is to say, as you said, look at the reticulocyte index because it tells us, is the bone marrow working or is it, in this case, not working? So if I look at the reticulocyte index and it's greater than 2%, that means the bone marrow is working. So their loss of blood is not coming from an underproduction. It's coming from them destroying or losing blood. So it's either hemolysis or it's blood loss. So that's the way I would kind of go about in this step, is I know right off the reticulocyte index, I either have one or the other. And oftentimes there is other ways that we can go about determining this, but I just like to look at the patient's history. If they're exsanguinating in front of me, they're probably losing blood, not hemolyzing. And then I also look for like hemodynamic instability. I'd look for evidence of blood loss through other orifices, and I don't really see that. So I'm pretty confident, I'd say to some degree, that this is hemolysis over blood loss. But there is other ways that we can determine that.
And especially because, there's no petechiae, there's no bruising, there's no like physical signs.
Yeah, I don't see any physical signs, and that's the big thing for me, is that no trauma, no inciting trauma, no, if he had like melena, hematemesis, if he was bleeding from his leg and it was squirting like a squirt gun, then yeah, I'd be like, all right, don't worry about the hemolytic labs. Yeah, I'm pretty sure we know where the blood loss is coming from. You know what I mean?
Right. Yep.
So that's kind of the way I would think about it history-wise, but there is other ways that we can determine that.
What would you expect to find from the hemolysis labs if it is in fact a hemolysis was occurring?
Yeah, so I would say that the first thing is if you could order an LDH, you could order a haptoglobin, and you can order an indirect bilirubin. Those are the best ways that you could go about that. Funny enough, you gave those to me. So the LDH was elevated. Yep. That tells me that the red blood cells are getting popped open and releasing this enzyme out into the bloodstream. Haptoglobin is decreased. That means that haptoglobin is a protein that binds hemoglobin. If there's a lot of free hemoglobin around, haptoglobin will bind to that hemoglobin and it'll drop its free circulating level. So that will go down. That suggests hemolysis. And then indirect bilirubin is basically whenever you break down a red blood cell, you break down hemoglobin into heme and globin. The heme will get then broken down into bilirubin, but it's called unconjugated or indirect bili. If that's elevated and it's in higher levels than normal, that could also suggest hemolysis. So right away, I'm pretty sure that this is hemolysis, given the fact of these kind of labs.
Now that we know that there is hemolysis, what would be the next step in your approach to further evaluate the cause of the hemolysis?
All right, that's a good question. So now the next part in here is we know that it's hemolysis. There's so many different causes. Because we kind of started off with the first case where it was a little bit easier in the sense that like you kind of looked at the patient's hemoglobin, you knew that it was anemia, you looked at the MCV, you knew it was at normocytic, you looked at the retic index, you knew it was an underproduction. There's not a lot of causes of underproduction. It's kind of aplastic anemia, maybe some other cancers. or it's the anemia chronic disease. For normocytic anemias that are due to hemolysis, there's so many. There's so many causes. And so from there, the best test that I would say is to get a peripheral blood smear. So you usually get that with your CBC with differential. You just would have to have some type of pathologist or hematologist actually looking at the microscope and kind of looking to see what kind of like red cell morphology they have. And that's the key thing here is I would definitely go ahead and get a peripheral blood smear and see if I can find anything. For example, is there sickle cells? Is there Heinz bodies? Is there bite cells, etc.? If I find something like that, that can really lead me into saying, okay, this is my suspicion. Let me then confirm. So then it's a confirmatory test. So from here, I'm kind of just going off of suspicion. What's the blood smear show me? If it doesn't show me anything, that will also help me to determine where I'm going to go.
So given the absence of any specific blood smear findings, any thoughts on what you would do next in this case?
Yeah, so since they didn't show me anything on the blood smear, that usually automatically, I'd say for some parts, you can have patients who have blood loss, acute blood loss anemia, and have hemolysis, but I'd say that again, I don't think that's likely given the history. So what I would think is could this be paroxysmal nocturnal hemoglobinuria? And the reason why I think that is that the classic case of paroxysmal is they have dark colored urine. They have kind of like in this case, they're dumping out a lot of hemoglobin in their urine, and it's in the morning. And then the weird thing is I'm making kind of an assumption here, and it's kind of like a hypothesis, but episodes of abdominal pain, and then they have mild right upper quadrant tenderness. I wonder if they also have this weird like Budd-Chiari syndrome or portal vein thrombosis. So people with paroxysmal nocturnal hemoglobinuria, it's one of these weird diseases where they're supposed to have these proteins that break down complements or inactivate them. So complements don't stick to the red blood cell. They don't make those proteins. And so because of that, their complements build up and they destroy the red blood cells. Problem is when they destroy the red blood cells, it releases hemoglobin. Hemoglobin binds to nitric oxide, and that's supposed to prevent platelets from sticking to the actual blood vessel wall. If I can't do that, platelets will stick and they'll get clots. I have a feeling this person has hypercoagulable states from PNH, which is pretty common, but most often it affects like really weird places. You don't often get DVTs or PEs. You actually get like these weird clots, like sometimes in the portal vein or sometimes in the hepatic vein. So
would they then have hepatic involvement?
I think that there's probably some hepatic involvement here because there's probably congestion. So they're probably not getting blood out of their liver properly. And so it's probably causing some congestive hepatopathy, causing enlargement of the liver. And they're probably why they have some right upper quadrant tenderness as well. But that's my suspicion. So I definitely think it's PNH based upon the history, the lack of blood smear, and the presence of hemolysis, because this is a hemolytic anemia. So that's kind of what I would say. But the only way that I can truly prove this is to get what's called a flow cytometry. And you got to be really confident. If you're ordering these kinds of tests, you're probably a hematologist or oncologist. You're not going to find many like internal medicine docs like doing this. But if you did have a suspicion, you could order a flow cytometry to look for CD55 and CD59 proteins. The problem is that those are the proteins. These patients, they don't make an anchor protein, which helps to bind those CD55 and CD59. So I expect those levels to be lower. So if I get the flow cytometry, it'll show lower levels of CD55 and CD59. And that would be the way of me kind of confirming it's PNH.
Given the findings that suggest PNH, can you walk us through the treatment process of this disease?
Yeah, so with paroxysmal nocturnal hemoglobinuria, PNH, the big thing to remember for this is that, you can get venous clots, right? Like we talked about. I think that this one, probably a portal vein or a hepatic vein thrombosis, one of these two, pretty common with this disease. So I would consider anticoagulation if they have events like that. If they have any clots, we should probably prevent that so that it doesn't spread any further or propagate. So anticoagulation would be good. I'd say if they're having clots, though, and symptomatic events like how this patient has, and it's kind of getting more frequent with the morning urine that's getting dark, the fatigue, the things that they're experiencing, and then the actual events of venous clots, I would start them on an antibody called eculizumab, and it would basically block them from continuing to cause complement-mediated destruction of red blood cells. And so it will prevent the anemia and also help to prevent the results that can come with the venous clots. And so that's something I would consider. The next thing I would do is if the patient starts to develop what's called pancytopenia. That's what's weird with this one. This disease actually can cause pancytopenia. So you can actually start to experience them kind of losing the ability to make red blood cells, red blood cells, white blood cells, and platelets, because this is actually sometimes at the stem cell level too.
But unlike aplastic anemia, this one has a retic index greater than 2%.
Exactly. So this is one of those weird ones. But I would say if I start to see the retic index turn the other corner,
right?
So if you see the retic index going down, and you see that their blood cell lines are going down with PNH, that means that they've progressed and they're starting to kind of have an aplastic anemia picture.
Oh, wow.
And so then they actually need to get recommended for a bone marrow transplant. So that can actually happen with this one.
So it actually could transition into an aplastic anemia.
Yeah, it's kind of like it's a PNH with an aplastic kind of presentation.
Wow.
So yeah, so that's kind of the concern here. And if it starts to happen like that, then we got to refer them for kind of a bone marrow transplant if possible. So that's kind of the ways we would go about this one. Also, any hemolytic anemia that's chronic, you kind of have to make the bone marrow work hard. And so if the bone marrow works hard, you're going to be constantly using things like vitamin B12 and iron, but folate is the big one. And so sometimes people can develop like functional folate deficiencies. And so any kind of chronic hemolysis, we always give them folate. So that's something else I would consider. But eculizumab, anticoagulation for clots. And then if I need to, if they start to develop pancytopenia, retic index drops, looks like aplastic variant now, I would go ahead and refer for bone marrow transplant.
All right. Well, there's case 2. Let's go ahead and move right into case 3 now. We have a 30-year-old male, presents with jaundice, dark urine, after taking an antibiotic for a recent respiratory infection. The HPI, the patient reports dark-colored urine and jaundice after taking trimethoprim sulfamethoxazole, which is a brand name Bactrim.
Yep.
He denies any prior episodes of anemia or hemolysis. For our exam, vitals is BP 120 over 80, heart rate 88. There is jaundice present, and there is no splenomegaly. We get lab findings. Hemoglobin is 8.8. Our reticulocyte index is greater than 2%. LDH is elevated. Haptoglobin is decreased. MCV is 95. And we also have a peripheral blood smear here. And we note Heinz bodies and bite cells.
Good. Got some ketchup in there.
Yeah, Heinz ketchup. That's right. So same kind of questions as we've been going through here.
All right.
Let's knock them out one by one. The first one being, based on the lab findings, what type of morphological anemia are we dealing with, and why do you say that?
All right. So pretty straightforward here. This is a male. Hemoglobin less than 13 is defined as anemia. They got 8.8 anemia. MCV, 80 to 100 is normocytic. 95, so we got a normocytic anemia. That's kind of where I would start off with right there. And so then we got a big differential. So then we got to kind of divide it a little bit more, as we've kind of done.
Now that we know this is a normocytic anemia, what would be the next test you would order to suggest hemolysis blood loss versus underproduction of red blood cells?
Again, so kind of going back there, look at the reticulocyte index and see, are they kind of like responding? Is the bone marrow working? And so if the bone marrow is kind of like working really heavily and it's greater than 2%, it kind of suggests more of a hemolysis or blood loss than it does an underproduction. So that kind of gets rid of the underproduction anemias like aplastic anemia, anemia chronic disease, and you get into more of the hemolytic anemias or blood loss anemias. Again, look at the history. I don't really see any event like history that suggests trauma or bleeding from like large amounts from different orifices. So I doubt this is a blood loss.
Yeah.
But the best way to really determine if it is hemolysis is to order the appropriate hemolysis labs. So that's kind of what I would consider.
Based on the findings of the retic index, what would be the next test you would consider given the presence of hemolysis blood loss?
So I would say get the LDH, get the haptoglobin. Those would be the two things. You can also get the indirect bilirubin. Sometimes they say adding on the hemoglobin, particularly the urinalysis. Right. Look for hemoglobinuria. That could also be helpful.
But in this case, we have LDH elevated, haptoglobin decreased.
Yeah. So pretty much that would suggest hemolysis.
Okay. Now that we know there is hemolysis, what would be the next step in your approach to further evaluate the cause of the hemolysis?
So we know it's hemolysis based upon the LDH, the haptoglobin. The next thing I would say is we got to figure out what kind of hemolytic anemia it is. And so that's where we go to the peripheral blood smear. Look to see what kind of findings you have on there to see what is the morphology of the red blood cells that could guide my next step, which is the confirmatory test. So that's what I would say here.
So we have Heinz bodies and bite cells. Tell me a little bit about that.
So Heinz bodies and bite cells is classic for G6PD-H deficiency. That's what's important to remember. So PNH, which we talked about, has no specific peripheral blood smear findings, right? So then we had to go to the next step, which is a flow cytometry. Heinz bodies and bite cells, Heinz bodies are basically, in G6PD-H deficiency, you have a decrease in G6PD, right? Which is a glucose 6-phosphate dehydrogenase. It's involved in a lot of different pathways, but one of the big things that helps to generate these things called NADPH, which NADPH is an enzyme that helps to be able to kind of convert glutathione into a oxidized to reduced form. And so because of that, the benefit of that is that glutathione helps to kind of neutralize free radicals. If you don't have that enzyme, you can't make NADPH. You can't help to make glutathione where it's capable of treating those free radicals and preventing them from developing. So free radicals build up. They actually cause hemoglobin to kind of denature, and it gets stuck inside of the red blood cell membrane, and it causes these like weird little things. And then, funny enough, runs through the spleen. The spleen macrophages see that and they take a bite out of it. I'm not even kidding.
Wow.
And so they're trying to actually kind of phagocytose those red blood cells, and they cause like little chunks to be bitten out of it. And that's called bite cells.
So they're like literally getting chewed up as they go through.
Yeah. So those are usually pretty classic for G6PD-H deficiency. And so with that being said, I'm I'd have a high suspicion. So that's what I would do is I would say I'd have to go order what's called a G6PD-H level, the enzyme level, and see if it's low. Problem is you can't order this while they're in a crisis because it's gonna give you like a false result. So what you need to do is wait maybe a couple weeks, 2-3 weeks when they're not in a hemolytic crisis, and then check that G6PD-H level. Because usually what happens is these patients are usually self-limiting. The triggers, and that's what gives it away in the history. I kind of knew it even before I had a lot of information. It's when you see a person who has a kind of episodes of dark urine, or they have hemolytic events after an infection, or they took a sulfa drug.
Okay.
So anti-malarial drugs, sulfa drugs, an infection, those are usually really big triggers. And another one, fava beans. If you see fava beans, think G6PD-H deficiency. And it's because it kind of like it affects a lot of the actual glutathione levels. So that right there kind of told me that. And so I would kind of have a very strong suspicion of it being a G6PD-H event. And I would have just to wait until they're out of the crisis. And then from there, I could check that level and see if it's low.
Given the findings of G6PD-H, walk us through the treatment for this patient.
Honestly, you just kind of let it go. You don't really
just self-limiting. You're not doing anything different.
Yeah, you're not really doing anything. You just try to remove the triggers.
Okay.
So in this case, I would say they're on, was it Bactrim?
It was Bactrim. So discontinue, try something different.
I would try something different. Yeah. So to treat their underlying, like whatever they're on that for, which for respiratory tract infection, I would just try to switch it to something else that's not a sulfa kind of containing drug and try that as an alternative. But I would at least try and discontinue that and see if that helps in kind of reducing these hemolytic events. But otherwise, you're just kind of supporting them. If they get to the point where the hemoglobin drops in less than 7, you may have to transfuse them. But otherwise, should go away. You shouldn't have to do anything specific for this one.
Easy enough. All right. Well, let's move on then to case 4.
All right.
We have a 20-year-old female presents with fatigue and mild jaundice. She has a family history of anemia. HPI, the patient has had episodes of mild jaundice since childhood. Family members on her mother's side have similar symptoms. She denies any recent illness or drug exposure. For her exam, we have vitals of BP 115/75, heart rate 85. Again, we have mild jaundice and scleral icterus, and splenomegaly is noted. We get our lab findings back. Hemoglobin is 10.5. Our reticulocyte index is greater than 2%. MCV is 90. And we again do a peripheral blood smear, and we find spherocytes.
All right.
That might be the dead giveaway right there.
Yeah, that's a pretty good one, honestly. You know, I think like as you kind of asked these questions before, we've kind of seen like the consensus is that we kind of know that we're checking to look at the hemoglobin if it's less than 13 in this case. I'm sorry, actually less than 12 because it's a female.
Oh, true. Yeah, we switched it up now.
Yep. So we know that we kind of met that anemia picture. Look at the MCV to see if it's kind of like less than 90. I'm sorry, between the 80 to 100.
Right.
We know that that is the case. It's normocytic. From there, you would then kind of follow that same process and say, okay, I know that it's normocytic. What's my retic index? Retic index is going to be greater than 2% in this case. So I know that this is going to be a hemolysis or a blood loss. From there, you can kind of do other things. And so that's when we talk about the haptoglobin, the LDH, the indirect bili.
To just differentiate the blood loss and
Yeah, and you can look at the history. I think one of the big things here, though, is that sometimes you got to be careful. So sometimes LDH and haptoglobin, they're not always indicative exactly of hemolysis, like every type of hemolysis. So you can have intravascular and extravascular hemolysis, and it's really important to know that. And so always look to see if they mention the spleen. So if they have jaundice, if there's jaundice present, indirect bili is elevated. You can kind of have to some degree of assumption that there's probably elevated indirect bilirubin.
And then she has splenomegaly as well.
And splenomegaly. I definitely think there's still hemolysis, but it's not occurring in the vessels. And so that's extravascular hemolysis, but it is still hemolysis. And so that kind of fits in that definition of hemolysis. And so you kind of get to the point here where we kind of cover and we kind of say, okay, we've done at this point, got to the point where we say, we know that this is a hemolytic anemia. So we go back to the same point, which is like you said, what's the next step, which is you look at that blood smear, right?
Yeah, pretty cool. Well, so given the presence of spherocytes on blood smear, any thoughts on what you would do next in this case to further elucidate the cause?
Yeah, so spherocytes right there tells me it's likely between two things, hereditary spherocytosis and autoimmune hemolytic anemia. Autoimmune hemolytic anemia is a tough one because it's an antibody-mediated process. Hereditary spherocytosis is not an antibody-mediated process. It's actually a genetic mutation where you lose some of the proteins that give structure to the red blood cell, like ankyrin, which is a funny name, spectrin, there's band proteins, all these different things, but you lose the morphology, and so it literally looks like a sphere, and so it gets stuck in the splenic vessels. Autoimmune hemolytic anemia is an antibody-mediated process, and it also causes them to become spherical, but they get destroyed in the spleen as well because they kind of get tagged, and the spleen kind of then engulfs them.
I'm not going to lie. I thought because spherocytosis was in the name.
You think that'd be the one, right?
Yeah, like it's in the name.
Yeah, exactly. And so
but not necessarily.
Not necessarily. So you got to be careful. So if you see spherocytes, don't always assume that.
I made that mistake. I immediately made that mistake.
It's okay, but then you say, okay, how do I know it's definitely hereditary or if it's autoimmune? And that's where we order something called a Coombs test.
Okay.
Sometimes they call it a direct antibody test. And you're kind of just basically you're taking from their serum, you're testing their serum against particular antibodies like G antibodies and against these C3 kind of proteins. And so you're looking to see if they have a reaction, if they have a autoantibody like reaction. And so that's what I would look for to see if it's a positive test that suggests autoantibodies. That's autoimmune hemolytic anemia. If it's a negative or a normal test, it suggests there's no autoantibodies and it's more likely hereditary spherocytosis. So that's kind of how I would go in that way.
So let's say it is normal then. Would there be any other tests you would do to confirm the diagnosis?
Yeah. So then you take it to the next point, which is you say, okay, there's two other tests. They used to use something called the osmotic fragility test, where you take red blood cells and you put it in a hypotonic solution. Normally they lyse. But if they lyse really easily and really quickly, it suggests fragility. And that can suggest hereditary spherocytosis, but it's not a great test. So there's a newer test, which is becoming the gold standard. And it's called like this EMA binding test. It's kind of a molecule that binds to proteins on the red blood cell that guess what? In hereditary spherocytosis, if you don't have them, the EMA can't bind. Okay. And so when you test the EMA binding activity, it's a lot lower in hereditary spherocytosis as compared to a normal patient's red blood cells. So that's the test that we actually look for is they have a decreased EMA binding activity and an increased osmotic fragility on that test.
So that test is being done more frequently now than the fragility test.
Yeah, sometimes people just do both.
Okay.
But I'd say the EMA binding test is going to be the gold standard to say this is definitely hereditary spherocytosis.
Perfect. So now we can say, hey, given the findings that suggest the hereditary spherocytosis, can you walk us through what the treatment process of that would look like?
Yeah, so for this one, hereditary spherocytosis, because it's primarily a disease that you chew it up, the red blood cells in the spleen, they can get pretty bad splenomegaly. Like, so sometimes to the point where they can actually develop hypersplenism, where they chew up red blood cells and platelets and stuff. So
spleen's got to go.
Yeah, take that thing out.
Yeah.
So you actually could mediate the prevention of a lot of this kind of like events of hemolysis. And so splenectomy is sometimes the best way to go, especially if they're having frequent hemolytic events. So if they're having frequent recurrent hemolytic events, take the spleen out. That's the best way to go. It's really important to remember the spleen removes encapsulated bacteria. So you have to make sure that if you remove the spleen, you get them vaccinated against things like Haemophilus influenza, Streptococcus pneumonia, Neisseria, all of those things because they're at higher risk and they won't be able to remove those bacteria as well.
Right.
The only other thing is, again, any hemolytic anemia, always give them folate. Just to keep that bone marrow pumping so they don't develop like a folate deficiency anemia.
Let's keep moving along here. We're moving. We got about halfway through there, a little more than halfway.
Yeah.
Let's move on to case 5.
All right.
We have a 50-year-old female presents with fatigue, jaundice, and dark-colored urine. We're having a theme here with the dark-colored urine. She has a history of rheumatoid arthritis. So for the HPI, the patient describes fatigue, yellowing of her eyes, dark urine over the last few weeks. She has been taking methotrexate for rheumatoid arthritis. For the exam, her vitals are BP 130/85, heart rate is 90, jaundice and pale conjunctiva present, and she does have mild splenomegaly. For our lab findings, we have a hemoglobin of 8.5, a reticulocyte index greater than 2%, LDH elevated, haptoglobin decreased, MCV 92, and for her peripheral blood smear, we see parasites. Like before, right? But old Rob from 5 minutes ago would say, "Oh, this is hereditary spherocytosis."
Yeah, exactly. Not no more.
I'm not thinking so anymore.
No, not no more.
No. We've already eliminated that one.
Exactly. And again, I think this kind of goes back to what you said. You kind of set this up for the same concept, which is, my friends, you should know this by now, right?
I would think so.
They know this by now. Should I do it though?
I would hope so. You didn't do it before. Give them a quick recap.
So hemoglobin, again, for this one, female, less than 12. We got 8.5, right? Anemia. Then from there, look at the MCV, 80 to 100. It's 92. So we're good. That's normocytic anemia. Again, look at the reticulocyte index. Tells you if it's an underproduction or if you're hemolyzing or you're losing blood. Greater than 2%. We're hemolyzing or we're losing blood. Is there any evidence in this patient that they have blood loss? I don't see it. And then from there, look for hemolytic factors that could suggest that. I wasn't really given any kind of, well, actually I was. Like LDH is elevated.
I was going to say LDH,
yeah. And then the haptoglobin's decreased, and then they have splenomegaly, and guess what else they have? They don't list the indirect bilirubin as elevated, but they have jaundice.
Right. Yep.
So there's probably an elevation there. So this is definitely hemolysis. Now at this point, Rob, we know that there's hemolysis. We just have to kind of figure out what kind. And we've done this a couple times. Let me throw it back at you. What kind of test would you do next to kind of give yourself a little bit of an inclination of what kind of cause it could be?
We had a cut. I was wrong. I have to be honest with you, Ninja Nerds. We took that part out. I was so wrong. Let's just move past it though, because I'm not getting it.
I love his honesty. I love it.
I can't lie to them. I can't.
Oh, that's so funny.
I told him, we have to cut. I was so wrong. And maybe I'll get it though eventually.
Yeah,
got a few cases left.
Yeah, we got a bunch of them left, but it'd definitely be the what? The
peripheral blood smear.
That's right, baby.
He told me.
But if you get the peripheral blood smear, that should give you an inclination of kind of what's going on. And you kind of alluded to this, that it was spherocytes.
Right. It's just difficult to delineate from before. It's like now you would think, all right, well, how do you do that?
Yeah. So if you kind of like assumed, oh, well, dude, you already have the spherocytes, you probably weren't wrong. You could probably just say, oh, get the direct antibody test, which that's what I would say next, right? So again, that's kind of how I would go here, but I would say the spherocytes are telling me that this is likely either hereditary spherocytosis or it could lend itself more to the autoimmune hemolytic anemia here.
So then would you go then to the Coombs test like before?
Exactly. So you kind of like, you were right. It's just one more step where I'd say, get the blood smear, look for spherocytes. Oh, I have spherocytes. Which one is it? Hereditary or autoimmune hemolytic anemia?
That's where you can determine which one.
Exactly. So that's when I get my Coombs test again. And then I would actually look at my Coombs test and say, okay, what does my Coombs test tell me? Is it positive? In other words, I have some type of reaction present. In this case, where I see that the IgG antibodies are being present, and it's causing agglutination of the red blood cells, or is there C3 kind of like autoantibodies against it are causing agglutination of the red blood cells? And once I see that, that kind of tells me if it's an autoimmune hemolytic anemia. So, in this case, did they tell us if there was a positive Coombs test? No, but I would say that that's kind of what I would be most likely suspicious of, is that they're going to give us a positive Coombs test.
Right. And then just like before, it was not positive, and this time it would be. Then we could say, okay, hey, this is definitely something different going on here.
Yeah, so this is definitely autoimmune hemolytic anemia if it's a positive Coombs test.
Given the findings that suggest warm AIHA, can you walk us through the treatment process for this disease?
Yeah, so I would say, okay, we've gotten to the point where we know it's autoimmune hemolytic anemia given, like, let's say that we have a positive Coombs test, right? If we have a positive Coombs test, we know it's autoimmune hemolytic anemia. What is important to remember here is that there is two types, which you brought up, cold and warm. It's honestly pretty straightforward. It's dependent upon the temperature that you're actually, like the patient's at in the body. So cold is pretty rare, but we can see it if patients in cold temperatures, they definitely can get this kind of like agglutination reaction. Warm is going to be the more common one, though. We can see this a lot with like autoimmune diseases and even malignancies like CLL. Funny enough, this patient has an autoimmune disease. So that definitely is likely one of the triggers in this process. But I'd say if I had a patient that had a Coombs test and the IgG, like they had a presence of elevated or IgG antibodies that were causing agglutination, that suggests warm autoimmune hemolytic anemia. If they don't have IgG antibodies that are present and they have C3 autoantibodies that are present, that would suggest cold autoimmune hemolytic anemia, because cold autoimmune hemolytic anemia is actually classified by having the presence of IgM antibodies, which you don't test for in the Coombs test. So that's the way I would determine if it was warm, is if it's the presence of IgG antibodies that causes red blood cell agglutination. If they have warm, oftentimes it's about treating the underlying disease. So this patient has RA. You probably just have to kind of modify their medications to improve that. But what I would say is, oftentimes these patients, you have to kind of put them on corticosteroids for a little bit. And so funny enough, most patients who have RA, if they need to, they have like a flare-up, they'll be put on corticosteroids. Again, you're going to probably put them on a little corticosteroid like medication for a bit, see if you can kind of get that suppressed. Sometimes if you have trouble being able to get them off the corticosteroid or they're refractory despite the corticosteroid, then you can add on another medication called rituximab. So either can add it or you can switch to rituximab, because we obviously want to try to prevent people from being on steroids forever. So you can either add it or you can just switch to rituximab. And then if rituximab doesn't work, the last thing that you could do is oftentimes autoimmune hemolytic anemia, it's most likely hemolysis in the spleen. So what did we do in patients who had hereditary spherocytosis?
Spleen's gone.
We cut that puppy out, right? So that's what we would do in this scenario is if we can't suppress the immune system enough to stop this hemolytic process, then we'll just cut out the source of where it's getting chewed up, which is the spleen.
And then, of course, adding in those immunizations that you talked about.
Exactly. So if you cut the spleen out, you better get them immunized for all of those particular pathogens, the encapsulated ones. And again, any kind of hemolytic anemia, get them on folate just to prevent them from developing any kind of folate deficiency.
All right.
That's the way I would kind of go about that one.
I love it.
That was a good one, right?
That was a good one. That was cool. Let's move on then to case 6.
Okay.
So we have a younger patient. It's a 16-year-old male. Presents with severe pain in his lower back and his legs. His HPI, the patient reports severe throbbing pain in his legs and lower back for the past 2 days. He has experienced similar crises before, but he finds this episode pretty intense. For his exam, his blood pressure, 128/76, heart rate is 102. We get a pain level back. It's 9 out of 10. So it's this pretty severe pain he's experiencing.
Yeah.
There's no jaundice or hepatosplenomegaly. And again, he has tenderness in both of his lower limbs. Lab findings, we get hemoglobin of 7.8, reticulocyte index greater than 2%, MCV 92, and we do a peripheral blood smear. We get back sickle cells and Howell Jolly bodies. What a name.
That is an interesting name. All right.
So given the presence of sickle cells or these Howell Jolly bodies on blood smear, any thoughts on what you would do next in this case to further elucidate it?
Yeah, so again,
and you can do your run through if you want. If you feel like
should we do a quick one?
You, you could if you want.
All right. So again, we already know it's anemia, right? Based on the hemoglobin, we know the MCV, it's normocytic. We got the retic index that suggests a hemolysis kind of event, not really an underproduction. So then we kind of got to go to our peripheral blood smear. You were able to give that to me with the sickle cells and the Howell Jolly bodies, right? Right away, I'm thinking it's sickle cell anemia.
Sure.
Right? You can't go wrong with that one.
You can't dispute that fact.
So the only way that you can truly determine it is not just off of peripheral blood smear. You got to get a hemoglobin electrophoresis because you have to look for that sickle type of hemoglobin or hemoglobin S, which suggests that, there was a point mutation where you switched one of the amino acids up. So I get a hemoglobin electrophoresis, and usually what that would show is it show the presence on that. You'd see a new strip where you would see that it would light up on the hemoglobin electrophoresis of a protein called hemoglobin S.
So let's rewind for a second. What is that?
Hemoglobin S. So basically
electrophoresis.
Oh, so it's kind of a test, and it's a really cool test. You have these electrodes on one side. So you have a positive charge on one and a negative charge on the other one. Most proteins, what they'll do is when you put them into this gel, it moves into this little column, and basically it moves in the direction that you want them to actually go. So for example, depending upon the type of protein, when it moves through, it moves towards things that are opposite charge. And so they can separate out. So let's say you just took a big kind of chunk of proteins, all their different kinds of proteins. You put them into this little kind of hole, and then it'll move through the gel based upon its desire to move towards the electrical charge, and it separates them out. And so based upon where they separate out, you can try and identify what type of protein that may be. And so oftentimes they'll do that where they'll take the hemoglobin, put that into the little thing and see how it separates out. And you can tell if you have hemoglobin A1, hemoglobin A2, hemoglobin F, hemoglobin S, hemoglobin H, all these different types because they base it on where it's at and then on the molecular weight, etc.
That's pretty cool.
Yeah, it is pretty cool. And so if I got a hemoglobin electrophoresis, I would probably see an increase. I'd see a thick band for hemoglobin F, and I'd see another band for hemoglobin S, which you shouldn't usually see. And so that's kind of what would tell me that this would be sickle cell anemia.
So the hemoglobin S then is the really concerning one.
Yep, exactly.
Given the presence of hemoglobin S, the one that we're more concerned about on the electrophoresis, are there any complications or concerns that you should be aware of to push them to seek medical attention given a sickle cell episode?
It can also block off blood flow to the penis, so they can develop priapism. The other concerning feature is that it can actually block off blood flow to the pulmonary arteries. And so sometimes what can happen is if it gets stuck there, It blocks blood flow to where they can actually cause ventilation and perfusion. And so these can actually impair gas exchange. They can develop hypoxia, shortness of breath. They can develop really, really bad symptoms. Sometimes the actual blockage can actually cause infiltrates to form. And so sometimes it can actually look like the patient has pneumonia, and sometimes we'll actually can be duped by that. So acute chest syndrome, priapism, and stroke features are super, super concerning. And that should actually make me want to say, oh man, I really need to get on top of this, because dactylitis, that's not great. Having other situations that are also concerning, sometimes they can actually block off the blood flow to the spleen, and it can actually cause splenic infarction. Funny enough, it's not really funny, but it's terrible. But interestingly enough, what happens is when you block off the blood flow to the spleen and it infarcts, over time with repeated sickling events, they can cause their spleen to become to the point where it's no longer working, and they develop something called an autosplenectomy, where they get rid of their spleen on their own.
Oh, wow.
And it's crazy. And so sometimes they can actually develop a kind of like similar to you actually having a splenectomy. And so if you get a splenectomy, what do you always have to prevent against? Bacteria, such as the encapsulated ones. So the Haemophilus influenza, type B, the Neisseria meningitidis, Streptococcus pneumoniae. So it's really important to make sure that you vaccinate these people who have sickle cell, because they're super high risk, because they'll actually have autosplenectomy on their own.
Same situation as literally having a splenectomy.
Yeah, exactly.
How about like any cardiovascular events?
Cardiovascular events can happen, but I'd say the biggest thing that I would be concerned about is like the acute chest syndrome.
Okay.
And then I'd say the other thing that you can potentially see, I'd say it's really, really rare to ever see like an MI. It's not too common to see any kind of MI events. So I'd say stroke, moya. I'd say dactylitis, which is the hands and the feet, the avascular necrosis of the humerus, priapism, acute chest syndrome, and then the other thing is splenic infarction. Okay. Now, one thing I really want to make sure that they know is that this is really, really high yield. Let's say that you have a patient with sickle cell anemia, and all of a sudden you notice that their blood pressure's low, their hemoglobin's like 4.
Oh, wow.
That's a scary thing, and that can happen with the spleen. It starts to sequester tons of red blood cells. So it's called a splenic sequestration crisis. So if a patient has a history of sickle cell anemia and they have a massive, like greater than 2 gram drop in hemoglobin, so let's say that their hemoglobin was at one point, it was like 7, and all of a sudden it's like 4. So if they have a greater than 2 gram drop, blood pressure's low, I'm really concerned about splenic sequestration crisis. There's another one that can kind of be tough though, because it can look like it, and it's called an aplastic crisis. So aplastic crisis is sometimes if a patient gets infected with a parvovirus B19, so always look in the history and say, oh, they got infected by, like, they had a respiratory tract infection, because usually parvovirus B19 can be spread that way. What happens is the parvovirus B19 actually infiltrates the bone marrow and can cause them to not be able to produce red blood cells along with white blood cells and platelets. So they'll have pancytopenia, and the reticulocytes will go down. And then on top of that, they won't make red blood cells, and they'll hemolyze the red blood cells. Massive drop in hemoglobin and hypotension.
Will they present as aplastic anemia then?
It can kind of look like that, but they'll have hemolysis, and that's the big thing. They'll have hemolysis. Their reticulocyte count will go down because they're starting to actually not being able to produce them enough, and it's usually transient. So usually seeing the pancytopenia, the drop in the reticulocyte count, and then again having the evidence of hemolysis with the sickle cells, that's pretty common, and you got to be careful with that one. So aplastic crisis, kind of an aplastic presentation with a massive drop in hemoglobin. Splenic sequestration crisis, no pancytopenia, no reticulocytes that are dropping. It's just massive drop in the hemoglobin and blood pressure. So those are a lot of the complications that we can see. I think the biggest ones that I'm noticing here is dactylitis.
Right.
But I would really be careful. I just don't want the ones that really, really concern me: acute chest syndrome, refractory priapism, and stroke. Those are things that it's hard to come back from. So you want to watch out.
All right. So there's been a ton of complications that you've talked about, especially some that could really cause mortality.
Yeah.
What do we do then as far as the treatment process goes? Is there anything that we actually do maybe during a crisis? And then how about, most importantly, preventative measures?
Yeah. So when a patient's in a vaso-occlusive crisis, pain is the worst thing. These patients will often tell you, like you got to give me pain meds. And so we'll start them on pain meds. NSAIDs aren't going to be enough. You're probably going to have to start opioids. They're also probably going to need some IV fluids. All right. So I'd also give them some IV fluids. That's going to help, because one of the things that's kind of interesting is that if with this type of process, when they have that sickling, it can actually change the viscosity. And so if you give them a bunch of IV fluids, you actually help to reduce the viscosity of the blood and help to increase oxygen delivery to the tissues. So giving them pain medication will reduce sickling. Giving them IV fluids will help to reduce sickling. And then I'll give them oxygen, and that'll also help to reduce the sickling process and ensure I get enough oxygen delivery to the tissue. That's what I would do first. So I'd start IV fluids on the patient, I give them pain meds, and then I would start some oxygen. From there, let's say that the pain continued and they were still symptomatic, or they got complications, they got worse. Let's say that they started off with dactylitis and now they have acute chest syndrome, or they have something else that's going on. Despite me giving them IV fluids, pain meds, and oxygen, that's when I would actually say, I wonder if I should transfuse them. And so a blood transfusion can be an option. And you'd probably be like, well, Zach, the hemoglobin's 7.8. I'm not going to transfuse them. This is one of the only kind of times where we actually kind of ignore hemoglobin thresholds. And we say if a patient has known sickle cell anemia or sickle cell anemia, and they're having crises despite kind of the initial pain management and fluids and oxygen, we then go for a blood transfusion. Okay. So that's the one potential reason to do that. Another reason to give a blood transfusion is the two crises. So a splenic sequestration crisis, which is going to cause a massive drop in hemoglobin. It'll probably drop them below 7. Aplastic crisis, that'll also drop their hemoglobin probably below 7. And the only other thing, and I'll talk about this next, is let's say that they have acute chest syndrome, a stroke, or refractory priapism, despite everything else I've done, and they're not at a facility that does an exchange transfusion. Then I would do a blood transfusion.
Okay.
So those are the reasons you do a blood transfusion in a sickle cell patient. They're symptomatic. Don't give a crap about their hemoglobin level, though. Second is the splenic sequestration crisis. Third, an aplastic crisis. Those are going to drop the hemoglobin naturally down pretty low. And then the last reason would be if a patient has refractory vaso-occlusive crises, particularly stroke, acute chest, refractory priapism, and they're not at a facility that does exchange transfusion. If a patient does develop acute chest syndrome, they have stroke symptoms, and they're having refractory priapism, then I would prefer to go straight to an exchange transfusion. And you're literally removing the defective sickle cell-like hemoglobin and then giving them back a normal hemoglobin. And so it helps to rapidly decrease hemoglobin S and give them the right amount of blood. And so it helps to prevent a lot of viscosity problems. So exchange transfusions, way more superior than simple transfusions, but only some facilities will perform that. So that's the way I would go about this. IV fluids, pain meds, oxygen. Not getting any better, consider transfusion, blood transfusion. During the process, rapid drop in hemoglobin, but I'm concerned about splenic sequestration, aplastic crisis, transfuse. Refractory kind of priapism, stroke, ACS, can't do exchange transfusion, do the blood transfusion.
Okay.
They are at a facility and they have that, do the exchange transfusion. It's way better, rapidly drops the hemoglobin S, and prevents these high viscosity problems.
Now, I know we didn't talk about it with this patient, really the background of what caused this sickling episode, but let's just say in this case, he's 16, if it was exertional, shouldn't it basically just stopping the activity, maybe even having some like oxygen or something like that, wouldn't that basically resolve on its own?
It should. Your hopeful goal is to reduce that sickling process. And so that would be the hopeful goal, is that if you just give them some fluids to kind of pump up their blood volume, that may help. And then give them oxygen, that may reduce the sickling. And then again, giving them pain meds, that should reduce the sickling. And as long as you try and reverse the underlying trigger, you should be okay to avoid transfusions or exchange transfusions.
But sometimes it doesn't happen that way.
Exactly. So sometimes if it persists despite that, or they continue to remain acidotic, continue to remain dehydrated, they could continue to have an infection that's going on that it's not being treated effectively enough,
right.
They can cross over to the other side, unfortunately, and they can get worse and then not respond well. So that's how I do for the acute treatment. But once I've gotten them out of the crisis, which is what kind of like we're hoping for, my goal is to prevent them from having these crises.
Exactly.
And so that's where the best thing that we kind of found is that if a patient has frequent crises, there is a threshold. I don't know if it always is stuck to in practice, but greater than or equal to 3 crises within a year frame,
okay,
you should put them on hydroxyurea. So hydroxyurea is a drug that helps to bump up their hemoglobin F, which is fetal hemoglobin. And you're like, well, what am I bumping up fetal hemoglobin for? We do that because it's the type of hemoglobin that won't sickle. And so if I increase the amount of fetal hemoglobin, I can kind of crowd out the possible sickle cell hemoglobin and make sure I deliver oxygen to the tissues.
That's pretty genius.
Yeah. So that's what we try to do to help to prevent these recurrent events. So if they're having refractory kind of like hemolytic events or crises events, I'm going to start them on hydroxyurea. If despite that, then you start kind of talking about, okay, let's say I have them on hydroxyurea. They're still developing some crises events, or they're still having these kind of problems. What you can consider is trying to get them to get a bone marrow transplant. So that would be the ultimate goal in trying to kind of prevent them from having these stem cells that form the sickled hemoglobin. But that would be the desired goal, the ultimate cure, if you will, is to do a bone marrow transplant. But sometimes that's a little bit tough, but that's what I would kind of aim for if, despite the hydroxyurea, they were having these events.
As like a last resort.
Yep. That's kind of the way I would go about this one for the acute treatment, and then hopefully prevention, and then if possible, the ultimate cure.
Okay. Well, that was a big one with sickle cell. Let's move on to
big
the next.
mama.
Yeah, it was a big mama. Let's move on to case 7 here.
Okay.
Only 2 more left. We have a 45-year-old female presents with fatigue, jaundice, shortness of breath. She reports recent abdominal pain and gum bleeding. The HPI, the patient describes a fatigue, jaundice, and bleeding over the past week. She also has had abdominal pain and recent confusion. For her exam, we have some vitals. BP is 140/90, heart rate 100. Skin, there is jaundice and petechiae on extremities, and for her abdomen, there is mild tenderness present. We get some lab work back. We get some lab findings back. We have hemoglobin 8, platelets 50,000, reticulocyte index greater than 2%, LDH elevated, haptoglobin decreased, MCV 92. We also have some new findings here, some other labs that we've done. PT-INR elevated, PTT elevated, D-dimer elevated, fibrinogen is decreased, and for our peripheral blood smear, we see schistocytes.
Mm-hmm.
That's a new one.
That is a new one.
What are schistocytes?
They're like basically take red blood cells and explode them.
Oh, wow.
Yeah,
Okay.
you're just really just breaking them into pieces, and so that's what they kind of look like, is just broken up pieces of red blood cells.
So then with these findings, especially I'm seeing the LDH haptoglobin, we're assuming hemolysis again.
Yeah. So elevated LDH, decreased hemoglobin, and then the jaundice, probably elevated indirect bilirubin. We probably got some hemolysis going on.
Because like
there.
before, you would think with she's having some bleeding and things like that.
Yeah, you would, right? Because there's bleeding
You
from
would
the gums and things
that's
like
what I
that.
thought right away.
Yeah, so you would think, oh, this could be an acute blood loss anemia, but the fact that there's hemolysis, there's hemodynamic stability, I'd say it's unlikely like an acute blood loss anemia, especially given the hemolysis factors here.
All right. So going back to the schistocytes, any thoughts on what you would do next in this case to further elucidate the cause?
Yeah, so the funny thing is, I think the bleeding is the result of something else. And I think it's kind of like associated with the hemolysis. So when you see schistocytes, right, that kind of suggest the MAHA. So we have the anemia, if it's in the normocytic camp. We have the retic index, which suggests that there's likely hemolysis or blood loss. The LDH and haptoglobin suggest hemolysis. Then you look at the peripheral blood sphere, schistocytes, think a differential. Think DIC, disseminated intravascular coagulation, TTP, thrombotic thrombocytopenia purpura, HUS, hemolytic uremic syndrome, and then HELP. So this is hemolysis, elevated LFTs, and low platelets.
Okay.
When you think about those 4 things, you then have to kind of think about the clinical context. So HELP syndrome is usually in a pregnant female. And so usually they'll have elevated LFTs, low platelets, proteinuria. This patient is not pregnant. There's no suggestion of that. So I'm going to go ahead and take HELP syndrome likely off the table.
Okay.
The next one is HUS. Usually this is in younger patients after they've had some type of like gastroenteritis. So they've had some type of like recent gastroenteritis, and they'll have acute kidney injury. They'll have thrombocytopenia. And on top of that, they'll have anemia. And again, there'll be a preceding gastrointestinal illness. I don't really see that. So again, I'm not going to say that's the likely cause. And then the next one is the TTP. That's usually patients develop fevers. And I don't think that they have mentioned any fevers. There's nothing in the vitals to suggest that, though.
No, nothing here.
And then the next part is they have anemia. They have thrombocytopenia. And then on top of that, they have renal failure. So they would have an AKI. We don't have that listed. And they would have neurological symptoms.
Which we kind of do. So she has recent confusion.
Oh, does she?
Yes, she does.
Oh, again, possibly. So that's something to think about.
Or is that maybe just kind of...
No, it is important to think about. But here's where I'd say the last part. The last one is DIC. And so DIC, if you have abnormal coagulation parameters, it kind of, for the most part, knocks out all the rest of them.
And so she definitely does.
Yes, TTP, HUS, HELP syndrome, they shouldn't really have all these abnormalities in their coagulation parameters.
You should have started with that.
I probably should have, right?
No, I'm kidding. That's awesome.
So with DIC, if I see in these patients, what happens is usually it's in the setting of sepsis or obstetrical complications, or it could be a variety of things. But what happens is they form widespread clots all over the body. And then these clots, as the blood is rushing across those clots, the clot shears the red blood cells into pieces. And that's where you get the schistocytes.
Wow.
But on top of that, when you rip the red blood cells out, also you're forming clots. So you're using platelets to make clots. If you use platelets to make clots, you drop down the platelets, and if you rip the red blood cells across these clots, you drop down the red blood cells. So that's how they get anemia and thrombocytopenia. But they're going to have clots all over the place. Here's the problem. Because they consume so many of their clotting proteins to make these clots, their coagulation parameters become off because they consume their clotting proteins. And so if you consume your clotting proteins, you won't be able to clot. You're more likely to bleed. That's why she's probably bleeding.
Okay.
And if you have higher tendencies of bleeding, your time to clot is going to be affected. So the PT-INR will be elevated, the PTT will be elevated, D-dimer, which is kind of a measure of that, would also be elevated, and fibrinogen is getting consumed in this process, so it would be decreased. So all of these things really kind of like scream to me that this patient is probably having DIC. So that's kind of what I would go with as the likely kind of cause here, given the abnormal coagulation parameters, the clinical setting, and again, in all the other scenarios that we talked about, TTP, HUS, and HELP, they won't have these abnormal coagulation parameters.
So with DIC then, how do we treat that?
Yeah, so DIC is a tough one. Usually patients don't usually do too well, right? Wow. So DIC, you have to treat the underlying cause. So whatever it is, treat that. If it's sepsis, treat the sepsis. If it's an obstetrical complication, treat that. But oftentimes it's supportive care. You're just trying to stop them from bleeding and stop them from clotting as well. And so funny enough, with these patients, you may have to give them things that normalize their actual coagulation parameters. You may have to treat that as well. But these patients, there's no specific treatment. It's more just supportive care and hope that they can kind of make it through it.
Are they getting any blood transfusions at all?
They could, yeah. So if patients kind of get to the point where the hemoglobin drops to less than 7, we would transfuse.
So she's close, but not quite.
Yeah. If there was hemodynamic instability, we would transfuse, or if they had pre-existing CAD or an acute coronary syndrome, we'd transfuse for a kind of a little bit more of a target a little bit higher.
Sure.
But there's none there, so I'd say 7 is the goal, unless there's a hemodynamic instability. But no, honestly, you would just be treating, you would be giving them different types of factors to help to decrease their PT-INR. So probably be giving things like prothrombin complex concentrate, probably giving them fibrinogen and trying to help to be able to bring that PT-INR down a little bit, and also trying to bring the fibrinogen up. And then the other thing is I'd probably just transfuse if the hemoglobin drops to less than 7. Everything else is just supportive care to hopefully get them through that.
All right. So overall, pretty much supportive care then.
Yeah.
All right. Well, there's case 7. Let's move into our last case here. We have case 8. Let's finish off here with a bang.
All right, let's do it.
We got a 55-year-old male present with weakness, lightheadedness, and dark stools for the past 2 days. For his HPI, the patient describes fatigue, weakness, and black tarry stools. He denies vomiting, abdominal pain, or weight loss. No history of blood disorders or recent trauma. For his exam, his vitals, his BP is 100/65, heart rate 110. His skin appears pale and is cool to the touch. Abdomen is non-tender, and during a rectal exam, it's positive for melena. Lab findings, we have hemoglobin of 5.5, MCV is 88, platelets are normal, and his reticulocyte index is greater than 2%. Right away, that hemoglobin is pretty scary.
Yeah. I was going to say, like, one time I ate like a whole pack of Oreos.
Oh no.
I remember having these, like, I hate to be like weird, but like I had a bowel movement. I was like, I'm dying.
Seriously, like I'm bleeding out.
One of my friends had beets one time, and he had like, just like, it looked like bloody urine. He's like,
that's happened to me before.
This is it. I'm done. I'm dying.
Yep.
But in all seriousness, this kind of patient, there's evidence of blood loss, probably a GI bleed.
Big time.
And so GI bleed with this kind of scenario, they're kind of like bad ones because they can get pretty bad pretty quick. But the vitals, I'd say they're right on the kind of cusp of getting to the point of almost going into the hypotensive range. There's probably a little bit of compensatory tachycardia. The heart rate's a little bit up. They're already vasoconstricting, and they've probably lost a decent amount of blood, so they're getting pale and cold to the touch because they're probably vasoconstricting to respond to that. And then having the positive melena, the presence of blood from the rectal exam is pretty concerning. And that hemoglobin of 5.5 ain't great, right?
It's just not, it doesn't look good.
Yeah, so I mean, honestly, you can go through this and you can say it's a normocytic anemia. The retic index is greater than 2%. If you wanted to, you could check those hemolytic labs. But I think for this, honestly, it really screams that it's blood loss.
Yeah.
And I wouldn't wait. So I think that's the stress point here, is that you can order the hemolytic labs, but don't kind of like wait until those come back to start doing something about this patient. I would say that in this patient, I be pretty confident that there's going to be no hemolysis and the LDH will come back normal and the haptoglobin will come back normal. I can't assume anything, but I'm going to say that that's likely the case.
I mean,
and so I would go with the
clinical picture is pretty much showing you that.
Yeah, so I'd say this is a GI bleed causing acute blood loss. There's an acute drop in the hemoglobin. That's kind of the big thing for me here. So that would be my more likely consensus.
All right, awesome. Well, given the presence of hemodynamic instability, evidence of blood loss, organ ischemia, what is the treatment of choice in this scenario? And with that question, can you also walk us through the threshold for transfusions of packed red blood cells in anemia?
Absolutely, yeah.
Which you kind of did already a little bit in the past case.
It'd be good to recap it, though. But I think with this patient, we could go the distance of confirming with the LDH and haptoglobin. Let's say that comes back normal. It's not hemolysis. It's likely blood loss. From there, the big thing is to obviously kind of find the source of blood loss, right? Until then, though, we got to treat this hemoglobin and the instability that they're kind of getting ready to go into.
Yep.
So I'm going to go ahead and start off with transfusing them. I'd probably give this patient 2 units of packed red blood cells because 1 unit of packed red blood cells should increase the hemoglobin by 1 gram. So if I give 2, I could push them from 5.5 to 7.5, and I get above my threshold. The thing I kind of would do with that is start there, get them transfused, get them stable, and then I would start talking to my GI colleagues or interventional radiology colleagues to say, hey, we got to scope this patient, do an EGD, or in this case, it's actually, it's a black target stool. I would
say it's probably upper. Yeah.
So I do an EGD, kind of see if I can find any bleeding source and treat that accordingly to prevent the recurrence of that anemia. And if they can't go ahead and do that, then maybe we could do some type of CT angiogram or like an IR kind of study. But I'd say that would be the best way of kind of going about this is getting an EGD, finding that source and stopping it. But once we do that, we're good. That's really it. You just got to find the source of the bleeding and treat that. And then until then, just keep that hemoglobin greater than 7. And that kind of leads to the next question, which is if you have a patient who has these hemoglobins, which is pretty low, how do you know when it's a time to transfuse or not, right? We talked about sickle cell is the only one that doesn't follow the transfusion guidelines completely.
Sure.
But for the most part, we stand by that if a patient has a hemoglobin less than 7, you should transfuse them.
Regardless of history, anything.
Yeah, now you just hemoglobin 7, less than 7, transfuse. If a patient, and these aren't like, there's a lot of controversy behind these guidelines. These are off of up-to-date people, so it is coming off of a reliable source. But from what there is controversy about is the next parts. So hemoglobin less than 7 is usually a trusted, like most people say, all right, transfuse. Because you want to make sure that you're delivering enough oxygen to the tissues. When you get to the point where other organs are starting to become already ischemic, that's when arguments come about is should we push the hemoglobin up higher so that we give enough red blood cells to deliver oxygen to those ischemic tissues. So if a patient has coronary artery disease, like they have let's say that they have a history of I don't know, like they had a triple bypass, right? So they've had a CABG in the past and they have really bad arteries and it's known. I may push that hemoglobin a little bit greater than 7. I may go to 8. So
as your threshold.
Yeah. So pre-existing coronary artery disease that's pretty severe, like ischemic heart disease, and having a hemoglobin less than 8, I would probably transfuse just to push them right above 8. So let's say that this patient came in, they have a long-standing history of CAD. I may give them 3 units to push them up to 8.5. And so that's kind of the way that we would look at that. The last one is, and this is the most controversial, is if a patient is having an acute MI. If a patient's having an acute MI, that's when we kind of make the argument and say, oh, should we push it even higher? So some people say 8, that's it. But there's a newer thing where they actually say, let's actually go up if it's less than 10. So if it's an acute MI, they'll argue to say you should actually push it above 10. And then I'd have to give this patient like 5 units of blood, right?
Yeah.
So that's a lot of blood. And so sometimes we try to stay away from that strategy, but it's, again, up to date is suggesting, and their suggestions is if it's hemoglobin less than 10 in an acute MI, you're going to give them a transfusion to get them above that point. Less than 8 with pre-existing CAD, get them above 8. And then if they have no history whatsoever and it's less than 7, you transfuse.
Do you think there's any, based upon the controversy around this, do you think it's really institution dependent?
I think it's institution provider dependent.
Okay.
I think I'd probably lean more to the provider dependent.
Got it.
And I think the reason why is giving blood comes with risks. So giving too much blood, you're giving volume. You can volume overload a patient. And so that's a concern. You also risk transfusion reactions. And so sometimes being kind of more restrictive is a little bit better.
Yeah.
And so I have stood in the camp of working with other physicians that say that, hey, I think we should kind of stay with this lower threshold. And most won't go above that 8, and they won't touch that like hemoglobin of 10.
Right.
But again, that's some of the guidelines. There is some cardiac kind of like guidelines that are suggesting, hey, hemoglobin less than 10 with an acute MI probably could transfuse. And again, that's kind of the guidelines. The last one to transfuse is if they have you have a strong suspicion that they have blood loss and that's the cause of their hemodynamic instability. Give them blood, and it doesn't matter. You give them blood until their blood pressure is normal. If I have a patient with a blood pressure of 40 over dead, I'm going to give them blood until it's not 40 over dead, and then I can go ahead and say, okay, cool, let's check their hemoglobin. Oh, okay, it's normal, good. So my goal is to, if they need blood to transfuse them, hemoglobin less than 7, no history. Hemoglobin less than 8, pre-existing CAD. Hemoglobin less than 10 with an acute MI. But if they have blood loss, and I know that's their cause of hemodynamic instability, transfuse until they're not hemodynamically unstable.
Which is pretty obvious in this case.
Yep. So that's kind of what I would go with as the indications of transfusing someone.
That's it.
That was a monster.
That is normocytic anemia. That wasn't as long as I thought it would be.
It felt like forever.
I know. We had like 4,000 takes.
Yeah, this wasn't one good take, guys. I'm sorry.
No. We had a lot of fun.
Yeah, it was
we had a lot of fun.
But I think that this is a really cool lecture because I think that just goes to show you that hematology is thick.
It's intense.
If you have a straightforward approach, it makes it a lot easier because again, it's systematic, right? In the sense that, is there anemia? What's the MCV? Once you determine that, is it underproduction or is it hemolysis or blood loss? Once you determine, oh, it's hemolysis off the LDH, hapto, indirect hemoglobin, bilirubin, spleen stuff. All right, cool. Go down that path. Get a peripheral blood smear. See what that shows you. Based upon that, you may order other tests to either confirm or deny your diagnosis. You go down that blood loss camp. Cool. Where's the source of the blood loss? Let me go ahead and figure that out. And then if it's not a hemolysis or blood loss, then you're left with that underproduction, that retic index, right? If it's less than 2. Then you say, is the bone marrow not working at all? What's the other cells doing? Is there less white cells, less platelets? Let me look at a bone marrow biopsy. If it's not, then you kind of think, okay, if there's no pancytopenia, I wonder if this is like an anemia of chronic disease. And that's the one that we kind of just like spit out at the last as a diagnosis of exclusion.
Okay.
But I think that's the key. And then once you get your diagnosis, the key point to take away is that not every single type of anemia has the same treatment. And that's what kind of gets tough, is because you have to remember multiple treatments for multiple different types of normocytic anemias.
I think that's why it's crucial, because we're going to offer these lectures. We're going to do it whiteboard style,
Yep.
and also our digital style. And we're going to provide diagnostic algorithms and a lot of different treatment approaches, and they're going to be critical. So seriously, check it out, because we're going to offer a lot, because this stuff is not easy. So using these resources, take advantage of them.
And I think the quizzes, like after you're done reading it, I think that's the best way to test your knowledge, is going through and seeing if you can analyze that. So I think a lot of times anemia is scary, but if you kind of try your best to think about it with a systematic approach every time, I think it makes it a little bit simpler. But
I sure do too.
man, I had fun with this podcast.
This was a lot of fun.
Yeah.
It's cool.
And I hope that you guys enjoyed this podcast as well. I hope that you liked it. I hope you learned a lot. And yeah, I love you guys. Thank you guys. And as always, till next time.